Sticking around. So this first video will be on the framework for understanding undifferentiated shock. The second video, which we'll link in the video description, is going to be using this framework to understand the four general shock states, being distributive, cardiogenic, hypovolemic, and obstructive shock. So again, linked in the video description if you're interested in that, but this one will provide the framework to understand that one. So to start with, we need to make sure we're using kind of the same lingo, right? The same definition. So we're going to define what is shock, all right? And shock in its simplest form is tissue hypoxia. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest whiteboard medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. Right? It's essentially that the tissues do not have enough oxygen as compared to the amount of oxygen they're consuming. And this eventually will lead to organ injury, and it's, in its worst sense, multi-organ failure. Right? Because as those tissues don't get enough oxygen, those cells start to die. And as the cells start to die, the tissues start to die. And that's when we start to see kidney injury, liver injury. You can get demand ischemia in the heart and eventually multi-organ failure, which can lead to death. Shock, a lot of times you're hypotensive or your blood pressure is low. A lot of times you have a high lactic acid. But in its simplest form, it's tissue hypoxia. Well, how do we understand tissue hypoxia? This is a great concept, but how do we actually understand what that means? And that's where we come into the bulk of this lecture, the framework. Right? Tissue hypoxia means those tissues aren't getting enough oxygen delivered as compared to the amount of oxygen they're consuming. And that might be because the heart isn't able to deliver enough oxygen, cardiogenic shock, or it might be because those tissues are consuming so much oxygen because they're in overdrive, like septic shock, you have an infection. But even this introductory start, it doesn't really give us graspable bits, right? This makes sense, it's true, but it's not really clinically actionable, right? What is oxygen delivery? How do you make it better? So what we're going to do is we're going to break oxygen delivery down into smaller and smaller bits until we get to a point where we actually have clinically applicable parts of this equation that we can manipulate and think about with an actual patient. Oxygen consumption can be measured, it can be manipulated a little bit, but for the sake of this video, oxygen consumption is going to stay stagnant. So shock is tissue hypoxia. Shock is we're not able to deliver enough oxygen as compared to the amount of oxygen the tissue is consuming. But what is oxygen delivery? How do we break it down? Well, oxygen delivery, if you really think about it, is just cardiac output, the amount of blood being pumped out of the heart. And you're going to see a lot of pluses in here, but this isn't really a true plus in the mathematical sense. It's, proportional to combined with all that kind of stuff. So don't worry about this being a true plus. But cardiac output, the amount of blood being pumped out of the heart, and the amount of oxygen in that blood, or the arterial oxygen content. This makes sense, right? How much oxygen is going to a tissue is dependent on how much blood is flowing to that tissue, and then how much oxygen is in the blood flowing to that tissue. These, though, still are not really clinically actionable, right? How can we measure or manipulate these two things? Well, you can break them down further. So cardiac output is broken down into heart rate and stroke volume. So heart rate being the amount of times the heart is squeezing, right? How many times the heart is pumping blood out of it towards the tissues. And stroke volume is the amount of volume of blood that the heart is pumping with each squeeze, right? How much blood is coming out of the heart each time it pumps. And that represents the cardiac output. It makes sense, right? If the heart rate is 60 beats per minute and the stroke volume is, I'm just going to make up a number for simplicity of use here, 50 cc's of blood. So every time the heart squeezes, 50 cc's of blood gets pumped out. The cardiac output is going to be, am I doing my math right? 3 liters, I guess? Someone can correct me if I'm wrong. Or 3,000 milliliters. A cardiac output, right, per minute. If it's pumping 60 times per minute and it's pumping out 50 cc's of blood every squeeze, it's going to be 60 times 50, right? And again, ignore these pluses. This would actually be multiplication. So now we've broken down cardiac output, but what about the arterial oxygen content? Well, what drives how much oxygen is in the arteries? And we actually know what drives that, right? So we know that hemoglobin, which is the molecule in a red blood cell, right? You get all this hemoglobin, carries oxygen on it, right? So within a red blood cell, the hemoglobin carries oxygen on it. So the amount of oxygen in the arteries is going to be proportional to the hemoglobin, right? The more hemoglobin we have, the more oxygen it's carrying. The amount of oxygen that hemoglobin is carrying is proportional to the amount of oxygen saturated in the blood, or the SaO2, the arterial oxygen saturation, right? And you actually can kind of measure that on the pulse oximeter on the monitor. So let's just say your oxygen saturation is 100%, right? That is going to be a higher amount of oxygen in hemoglobins than if your oxygen saturation was 60%, right? Because there's less oxygen available to be loaded onto the hemoglobin. And then the other part of this, which is a much smaller part, is the PaO2. This is just the dissolved oxygen, right? So in the blood, we have a blood vessel. And in the blood, we have red blood cells. These are actual cells. And in the red blood cells, you have hemoglobin molecules. And on the hemoglobin molecules, it's carrying oxygen, right? As we talked about. But oxygen also can just dissolve into the blood and not be carried on the hemoglobin molecule. And that is the PO2, or the partial pressure of dissolved oxygen in the artery. And that is what makes up the arterial oxygen content, right? It's the amount of hemoglobin, and it's the oxygen saturation on that hemoglobin, and then it's the amount of dissolved oxygen in the blood, right? So dissolved oxygen, hemoglobin, and oxygen saturation. And that's what's going to make up the oxygen delivery, right? It's going to be the cardiac output as determined by the heart rate and the stroke volume, and the hemoglobin, oxygen saturation, and partial pressure dissolved oxygen. Now we're almost to actionable bits, right? We're getting closer. If you wanted to increase oxygen delivery, you'd have to increase the stroke volume. How would you do that, though? You can break this equation down just a little bit further, right? So heart rate stays the same. We can measure heart rate on the monitor. We can manipulate heart rate with medications. Stroke volume, though, can be broken down into even smaller bits, right? And that is the preload, the contractility, and the afterload. That is what stroke volume is proportional to. What does this mean exactly? Well, to do that, we're going to draw a heart. Let's see if I can draw a heart. There's the atria, there's the ventricles. So we have the right ventricle, the left ventricle, the right atrium, the left atrium. All right, we know that veins dump venous blood onto the right side of the heart. So this is vein, and then we know that the left side of the heart pumps blood out to the lungs and the rest of the body through arteries. So the amount of blood the heart is squeezing out each minute is going to be proportional to the preload, which is the amount of blood flowing into the heart from the veins, the contractility, or how hard the heart is squeezing with each pump, and then the afterload, or the pressure that the heart is pumping against, right? So does that make sense? The stroke volume, how much blood is coming out of the heart with each squeeze, is going to be proportional to the amount of blood loading into the heart, right? Because if the preload is too high, you're going to stretch that ventricle, and then it's not going to be able to squeeze as hard because it's so stretched. If the preload is too low, you're not going to really be able to fill that ventricle, so even if it squeezes hard, there's just not that much blood in it to start with. So you want kind of that perfect amount of preload where the ventricle is stretched just enough that it's full and it's loaded and ready to squeeze. Then the contractility, right? If the ventricle's full of blood and it only squeezes a little bit, the stroke volume, how much blood it's pumping out, is going to be less than if it's squeezing, if it's contracting more robustly, right? So contractility. And then the heart, the ventricle is pumping against an afterload, right? So if it's pumping against a bunch of afterload, it's not going to be able, even if it squeezes hard, it's not going to be able to pump as much blood out with each squeeze because that afterload is high, right? So that is what stroke volume is proportional to. And these are measurable and actionable things, right? We can think about and measure how much blood is flowing into the heart, the preload. It's a much more detailed lecture on the intricacies of things like central venous pressure and IVC assessment and all that kind of stuff outside the realm of this lecture. But there are surrogates that we can look at that help us understand if the preload is adequate. Same with contractility and same with afterload. So these are measurable and manipulable things. And then the arterial oxygen content, same equation, but there are just some constants here so you can understand what's most important. You can see that the hemoglobin you multiply by 1.34 because the amount of hemoglobin is much more important to the arterial oxygen content than the amount of dissolved oxygen, which you multiply by 0.003. Again, check out that other video linked in the video description for more detailed dive into this equation. But this is the framework we're going to use to understand the 4 shock states, because the 4 shock states, the problem going on that's leading to shock is going to be related to a part of this equation, and then what we can intervene on to try to fix the shock state is also going to be related to this equation. So the 4 shock states, this might be familiar to some of you, maybe not familiar to others, but shock, as we talked about in that first video, we defined as tissue hypoxia. And when tissue hypoxia occurs, it can be from a lot of different things. Maybe the heart isn't squeezing hard enough to pump blood forward. Maybe you're bleeding and don't have enough hemoglobin. Maybe you're in septic shock and your tissues are utilizing an incredible amount of oxygen. We divide these into 4 general categories of shock to help us better understand what exactly is going on. Within each one of these categories, though, there's multiple different causes. So the first category, and often the most common category, one study from a level 1 center found that of all patients presenting in shock, 64% of them were in something called distributive shock. We will further understand distributive shock and define it in a bit, but distributive shock is also broken down into multiple different subcategories, things like septic, endocrinopathies. Again, we'll talk about this more in a bit. The second most common cause of shock is hypovolemic shock. You could be very dehydrated, you could be bleeding, etc., etc. After that is cardiogenic shock, a pump problem, the heart isn't squeezing hard enough. And the least common cause is obstructive shock. Maybe you have a massive blood clot. You have fluid around the heart causing tamponade. Again, all things we'll talk about. So we categorize shock into these 4 general categories. But know that these aren't perfect silos. So even within the 4 categories, so within distributive shock, we're going to talk about a bunch of different things that can cause quote-unquote distributive shock. But all of them behave a little bit different. So we use these 4 general categories to help us understand shock, but it's not perfect. Things are not totally uniform within each specific category. So to start, distributive shock. What is going on? What is distributive shock? Well, what happens in distributive shock is you often get a degree of systemic inflammation. Sometimes this is from septic shock, or you have an infection that is causing systemic inflammation. This could also be from things like pancreatitis, right, where you get a large degree of inflammation throughout the body because your pancreas is inflamed. You also sometimes see distributive shock with things like endocrinopathies. So maybe your adrenal crisis. Endocrine, I put a P too soon. This is why I shouldn't try to spell things in real time. Not that anyone could read my writing anyways. Endocrinopathies. You can also see this with anaphylaxis or a severe allergy, where your body starts to have a large degree of systemic inflammation. What happens here is you get vasodilation, or your blood vessels start to dilate, and then those blood vessels get leaky, or the capillaries start to leak more tissues into the interstitium. So the capillaries, many of you know, but you have arteries that go into arterioles, that go into venules and veins, right? And this is kind of what the system looks like all throughout the body. right? Blood flows with oxygen through the arteries. The capillary here, cap, has kind of the gas exchange, right? Oxygen goes into the tissue, CO2 goes into the capillaries, and then blood flows through the veins up to the heart, right? So artery, vein, capillary. Well, these capillaries start to get more leaky, right? They start to have kind of more gaps in them. So then fluid can flow into the tissue to get increased capillary permeability. If we look down here, this equation, this is from the first video. It's the oxygen delivery versus oxygen consumption equation. Because we said shock is that you can't deliver enough oxygen for the amount being consumed. And the reason in this case you're having trouble delivering enough oxygen is because there's a much higher degree of oxygen consumption in distributive shock, right? You have this systemic inflammation. All your tissues are in overdrive. They're consuming a bunch of oxygen. All right. In addition to that, we said you get vasodilation. Vasodilation is going to decrease your preload and decrease your afterload. All right. So this is the pathophysiology going on. With a decreased preload and a decreased afterload, you're not able to deliver as much blood volume, right? If you guys watch that first video, you know that these three things are proportional to the stroke volume, right? And heart rate times stroke volume equals cardiac output, or the amount of blood the heart is pumping around. So the problem here is in distributive shock, you get vasodilation. Your preload's low, your afterload is low, so you can't deliver as much oxygen because your cardiac output could drop. You have increased oxygen consumption in the peripheral tissues. So what does your body do to compensate? Well, compensatory, you get an increase in your heart rate and an increase in your contractility. These two compensatory mechanisms actually lead to an increase in your cardiac output to try to keep up with oxygen delivery, this side of the equation, to keep pace with the amount of oxygen consumption. But at some point, if you get sicker and sicker, this compensatory mechanism, this increase in cardiac output by increasing heart rate and increasing contractility, cannot keep up with oxygen consumption. And that then leads to the tissue hypoxia, right? So the pathophysiology of distributive shock is vasodilation and increased capillary permeability, increased oxygen consumption in the peripheral tissues, decreased preload, decreased afterload. These are all pathologic changes. The compensatory change is an increase in heart rate, increase in contractility. And at some point, if you get sicker and sicker, that compensatory mechanism can't keep up and your oxygen consumption outpaces your oxygen delivery and you go into distributive shock. So how do we treat this then? Well, let's look at the pathophysiology going on. Oxygen consumption, really hard to modulate this, right? There's things you could try to do outside the area of this video. But in oxygen delivery, what things can you modulate? Well, your body already cranked up the heart rate and cranked up the contractility on its own. But we talked about how there's a decrease in the preload and the decrease in the afterload, and that those two things are decreasing the stroke volume. So what we can do is we can give fluids and vasopressors, right? Fluids and vasopressors like norepinephrine or Levophed to increase the preload, so knock that out, and then vasopressors to increase the afterload, knock that out, and as such modulate and increase the cardiac output even more to try to keep pace. So that's the treatment among addressing the underlying problem. To distributive shock, fluids and vasopressors to try to reverse the pathophysiology going on here. So see how this equation, the oxygen delivery and oxygen consumption equation, can guide the diagnosis and management. If you understand the pathophysiology, you can understand how to diagnose it and then how to intervene on it, right? The pathophysiologic change, the compensatory change, and then what we can do to help the body better compensate. All right, so that is distributive shock, the most common cause of shock. Within distributive shock, septic shock is usually the most common, right? An infection that causes, diffuse inflammation throughout the body. But pancreatitis, pneumonitis, other itises can cause systemic inflammation, endocrinopathies, anaphylaxis. Neurogenic shock is often batched in distributive shock, although it does behave a little bit different. Because in neurogenic shock, you don't get the compensatory increase in the heart rate. You remain bradycardic because neurogenic shock is going to be injury to the sympathetic chain, so you can't mount that compensatory tachycardia, but it's still usually batched in distributive shock as well. So that is shock state number 1, distributive shock. Shock state number 2, hypovolemic shock. So same exact pattern here. Hypovolemic shock can be from severe dehydration, right? You just don't have enough fluid in the body. It can be from hemorrhage or bleeding or losing too much hemoglobin. It can be from this entity called third spacing, which we don't talk about as much, but it's where too much fluid leaks into kind of other areas of the body. But the two big ones are dehydration, hemorrhage, or, even volume loss. So you have severe diarrhea. Things like cholera can cause severe volume loss. And the progression here is you get severe volume loss, as we talked about. That leads to a decrease in preload. So same pattern. With red, you get a decrease in your preload. All right. If it's hemorrhage, if it's bleeding, you also get a decrease in your hemoglobin, right? So now we're having a decrease in both the cardiac output part of this equation, as well as the arterial oxygen content part of this equation. To compensate, your body increases the heart rate, it gets tachycardic, and it vasoconstricts, it increases your afterload, right? So what that does then is that tries to maintain the cardiac output to keep up with oxygen consumption. At some point, though, if this gets so bad that even increasing the heart rate, increasing the afterload, cannot keep up with oxygen delivery, that is when you start to get shock. You start to get tissue hypoxia. So what can we then do to help optimize the oxygen delivery portion of this equation? Well, if they're bleeding and their hemoglobin's dropped, you can give them blood transfusions, right? You can increase their hemoglobin. If they're in hypovolemic shock, they're dehydrated, their preload is low, you can, we should stay consistent. Transfuse PRBCs, packed red blood cells. All right. If it's hypovolemic shock from dehydration or volume loss, and their preload is low, you can give them fluids. So again, see here this equation we can use to diagnose as well as identify what to intervene on. So hypovolemic shock, hemorrhage, dehydration, volume loss. In the United States, hypovolemic shock is mostly from hemorrhage. In other countries that have more cholera and things like that, it could be more from volume loss and dehydration, but primarily hemorrhage in the setting of trauma, which you're going to do blood transfusions. Why in hypovolemic shock are vasopressors not really a good solution? What do vasopressors do? Right? Vasopressors would increase afterload, but your body's already compensating by increasing the afterload. So giving vasopressors doesn't really help this condition that much because the compensatory mechanism going on here is increasing afterload. If we go up to distributive shock, we said, let's give vasopressors here, right? Because in distributive shock, you get vasodilation, you get a low afterload. So giving vasopressors will increase that afterload. Whereas in hypovolemic shock, your body is already increasing the afterload, right? You don't have vasodilation here. This is simply you don't have enough fluid, whether it's because you're bleeding or because you're dehydrated. You don't have enough preload. So you need to address that with fluids if it's dehydration or packed red blood cells. The packed red blood cells will improve the arterial oxygen content. The fluids will improve the cardiac output, right? And these things together will increase the amount of oxygen delivery that hopefully can then keep pace with oxygen consumption. All right, that was shock state number 2. Shock state number 3, cardiogenic shock. So cardiogenic shock is essentially the pump. The heart won't squeeze well enough. And this can be from a lot of different things, right? Maybe you had a heart attack or a myocardial infarction. Maybe you have severe valve disease. You have a really bad valvulopathy. Maybe you have, really bad I already said infarct. So anything that causes myocardial damage, maybe you have really bad, myocarditis, right, or inflammation of the myocardium. Anything that causes that heart to not be able to pump effectively. So what is happening then, right? We have myocardial injury or dysfunction, and the pathophys in this equation, right, heart rate, preload, contractility, afterload, think about what is going to be affected here. Right, because oxygen delivery to go into shock is not enough to keep up with oxygen consumption. And then we know oxygen delivery is proportional to these things. Heart rate these are all stroke volume together. So heart rate and stroke volume are cardiac output. And then this together, hemoglobin, oxygen saturation, and dissolved oxygen is going to be the arterial oxygen content. So what is deranged in cardiogenic shock? Give you a hint. I said it. Decreased contractility. The pump cannot squeeze well enough. So what your body does to try to compensate here is it increases the heart rate and it increases the afterload because it thinks that by increasing the afterload, you might be able to increase stroke volume and improve cardiac output. The challenge here is the body actually does somewhat of the wrong thing in cardiogenic shock, or it can turn into the wrong thing. Because if the heart is not able to squeeze as well, sometimes its compensatory increase in afterload leads to worse cardiac output because this pump that can't pump that well is trying to push against higher afterload. So this is one of the few times when our interventions sometimes are going to contradict the body's compensatory changes. All right, so what do we do in cardiogenic shock then? What do we intervene on? Well, the easy answer here is if contractility is worse, we increase contractility, right? We use inotropes like dobutamine or milrinone. You can use mechanical circulatory support, Impellas, balloon pumps, ECMO, all these things to help, contractility or take the place of contractility. All right. With the contractility suffering, sometimes we see an increase in preload as well, an increase in afterload. And as we said, these things can, even though the body's doing it to compensate, it sometimes can hurt the cardiac output. It can fall off the curve. So sometimes in these patients, we actually are going to say, we don't want you to compensate. We're going to decrease the afterload. We're going to give an arterial dilator, right? So afterload reduction can sometimes be a treatment. Things like nicardipine, I guess it depends on where you work, but nitroglycerin, nicardipine, clavitipine, all sorts of stuff to decrease the afterload. And then sometimes we want to decrease the preload because sometimes you get this venous congestion, right? If the heart can't pump well enough, you can't pump all the blood returning to the heart. So you sometimes want to diurese them, right? Try to get them to pee off some of this increased preload. So unlike the other shock states, cardiogenic shock, sometimes the compensation the body's doing can be bad for cardiac output, and we have to intervene to get these compensatory mechanisms offloaded by decreasing the afterload, decreasing the preload. And then the thing that makes the most sense here is augmenting the contractility, because that is what is pathologically reduced in cardiogenic shock. All right, so that was shock state number 3. Last but not least, obstructive shock. So obstructive shock is very polyfactorial. Fun word that I wrote. So the causes of obstructive shock are anything that causes obstruction to forward flow. So the big thing is a pulmonary embolism. All right, so pulmonary embolism, if we draw a heart, right atrium, left atrium, right ventricle, left ventricle. The right ventricle is going to pump blood through the pulmonary vasculature to the lungs, right? If we have a huge pulmonary embolism in this pulmonary vasculature, that right heart can't squeeze, and you go into right heart failure or obstructive shock, all right? Another one here, let me delete this, is going to be tension pneumothorax, all right? So tension, oh look, I forgot a Y, tension pneumothorax or PTX. So in tension pneumothorax, you have 2 lungs, right? And then you have a heart that sits here, and this is all encased in the thoracic cavity. Tension pneumothorax means you get a hole in the lung, which causes all this air to leak out into the thorax. This increases the pressure out here. That causes the pressure to increase so much this lung collapses, and it can squeeze on the heart so that the heart can't get enough filling of blood, right? Because all that pressure is pushing on the heart, and as such, it doesn't have enough blood to pump out. That is distinctly different than pulmonary embolism, right? This is that there's pressure squeezing on the heart, so it can't get enough preload to fill. Whereas pulmonary embolism is there's too much afterload that the heart is pumping against. So you can see here that unlike, well, more so than the other categories, there's a lot of kind of polyfactorial causes here. Another big thing is cardiac tamponade. So cardiac tamponade is the heart is encased in a pericardial sac, right? And this pericardial sac can sometimes fill. Ooh, did I freeze here? Touch off. Let's put the touch back on. The pericardial sac can sometimes fill with fluid. The pericardial sac can sometimes fill with fluid, right? And if this fluid is filling up and up, it will also compress on the heart, so it can't get enough preload to fill the heart, and thus it can't pump blood out. So when we talk about kind of the pathophysiology here and then the compensatory changes, it's all super variable. Some have increased afterload, some have decreased preload, some has decreased contractility, et cetera, et cetera. Something that you can count on is that, so we said like some of them cause decreased preload, some cause increased afterload, some cause decreased contractility. Compensatorily, you almost always get an increase in heart rate, right? Because we know heart rate, these three things are stroke volume, these make up cardiac output. So you always see an increase in heart rate. But the other modulation here, the other thing we intervene on, will depend on what's going on. If you have a huge pulmonary embolism, that's going to cause this huge increase in right ventricular afterload. So what we do is we go in and we try to get rid of that clot to decrease the right ventricular afterload. If you have a tension pneumothorax, that's going to cause a huge decrease in preload because all that pressure is not allowing venous filling of the heart. So what do? We can go and we can give a bunch of fluids and then also fix the pneumothorax, put in a chest tube so that there's not as much pressure on the heart, right? So chest tube. Same thing if it's tamponade, that's squeezing on the heart, decreasing preload. We can give fluids, or we can give, and then we drain the fluid with a pericardiocentesis. So lots of variability in obstructive shock, which again is why we're saying these four categories are good for kind of initial understanding, but they're very polyfactorial, they're very multifactorial. Not every state within each one of these general categories causes the same derangement. So septic shock. Well, if we start just by trying to define loosely what septic shock is a life-threatening, that's fair, subtype of sepsis that requires rapid recognition and treatment. It's characterized by circulatory, cellular, and metabolic abnormalities that can lead to really high mortality. So if we try to decipher this a little bit more, septic shock has two words in it. One is septic, the other is shock. Shock, at its most kind of basal definition, is systemic tissue hypoxia. And this is that your tissues, your organs, are hypoxic. They're not getting enough oxygen. And that leads to tissue damage and organ dysfunction and multi-organ failure. Okay, so that's shock just in general. Then we talk about septic. Well, we've talked about sepsis on this channel before. And we know sepsis is when you get an infection and it leads to a deranged immune response. And that deranged immune response, although it is intended to help you, actually can cause organ injury. So septic shock is where you have sepsis and it causes shock. And yes, it's life-threatening. Yes, it requires rapid recognition and treatment. And yes, it's characterized by circulatory, cellular, and metabolic abnormalities that can lead to a high mortality. So all of that is true. If we think about what exactly it is, well, there is a formal definition, okay? We kind of talked about the informal definition, which was sepsis and shock, right? So it's when sepsis causes shock. But the formal definition we get from this thing called Sepsis 3, and this is a large kind of formal governmental organization that was birthed by CMS, although it has a lot of buy-in from different specialties as well. So this is somewhat Americanized, but it is applicable in other countries too, and there's certainly kind of international involvement in the definition of all these things. But they essentially define it below. It's when you have sepsis and you're in shock requiring vasopressors to maintain a MAP goal of greater than 65 millimeters of mercury, and this is despite fluids, and you have a lactate greater than 2 millimoles per liter. So this is the kind of textbook organizational guideline definition of septic shock. So you need to have a MAP, a mean arterial pressure of less than 65 millimeters of mercury after fluids. So it can't be that they came in with a MAP of 60, but then you gave them a liter of fluid and their MAP normalized. This has to be a MAP of less than 65 after fluid resuscitation, okay? And you need to require vasopressors to maintain that MAP. So this can't be someone with, quote unquote, chronic hypotension or someone who is not requiring vasopressors. Their definition is MAP of less than 65, requiring vasopressors after fluid resuscitation. And then you have to have some sign of end organ damage, which is why they have this lactate greater than 2 millimoles per liter, because this is a sign of end organ damage, and we'll talk a lot more about that. Okay, so that's the formal definition of what septic shock is. Obviously, the preceding rule here is you also have to have sepsis. You have to have an infection somewhere. So it has to be an infection that is leading to host immune dysregulation that then is leading to hypotension, a MAP of less than 65 after fluid resuscitation, requiring a vasopressor with some end organ damage, that lactate greater than 2. Okay. If we go to more informal definitions, sepsis with shock is profound circulatory and metabolic dysfunction, right, that can lead to that tissue hypoxia, which can lead to hypotension and shock. The mortality of sepsis is really high. Here we quoted 40 to 50%. You'll see things ranging from 20 to 50%. So the mortality of septic shock is very, very high. The reason for that is we honestly don't have great treatments for septic shock itself. We certainly have treatments for sepsis, and we certainly have bundles and things we do to try to address septic shock, but a lot of the dysregulation, which we'll talk about in the pathophysiology, doesn't have this firm treatment that can reverse that immune dysregulation, right? We kind of support the body and treat the underlying cause of the septic shock. And as such, this mortality has remained really, really high over time. The pathophysiology of septic shock, well, as we mentioned, septic shock results from a dysregulated host response to infection. Let's just ponder that for a minute because this is really, really important. So you need to have an infection and you need to have a dysregulated host immune response. That's your body saying, okay, there's an infection. I got to go attack that infection with my immune system. But that immune system activation is dysregulated to a degree where that in and of itself starts injuring cells in the body. Because your immune system has mechanisms to kill bacteria and viruses and parasites and fungi and cancer cells and all sorts of stuff. But those can also injure your own cells. So if you have dysregulation of that host response, that can lead to injury and death of your own cells, which can lead to tissue injury. It can lead to, release of more metabolites that then can cause vasodilation and some of these other things that we'll talk about in a second. So when you have that dysregulated host response, something starts to happen. And we're going to do an advanced septic shock lecture on the pathophysiology to really dive into this. So definitely subscribe and keep an eye out. It'll be both on the YouTube channel, Patreon page, as well as the podcast. But what essentially happens is you start to get immune cells, and we're going to do a little drawing here. You start to get immune cells. Let's just say we'll draw this here, that have these receptors on them. And there's a whole slew of different receptors. One of the main ones people talk about are TLRs, toll-like receptors. When you have bacteria or viruses or things that are in the body, the toll-like receptor can recognize those. It can activate. There's things like pathogen-associated molecular patterns, PAMPs. There's also a DAMPs. But that activation then leads to this massive release of cytokines. Cytokines are a whole bunch of different molecules that essentially get released throughout the body and augment the inflammatory and immune response. So once there's those cytokines released, it starts to attract different immune cells, but it also can modulate some of our blood vessels, and you start to get vasodilation. So if this is your blood vessel normally, it starts to dilate. Let's just do some symmetry here. It starts to dilate, okay? So this would be the normal size of the blood vessel, more narrow, and then you start to get this release of cytokines, and it causes vasodilation, okay? Vasodilation. That vasodilation can lead to a degree of hypotension because as those blood vessels dilate, you still have the same circulating blood volume in larger dilated blood vessels, and that can lead to decreased blood pressure, hypotension, that map of less than 65 we talked about. But that's only one piece of the puzzle, because the other thing that these cytokines do, if we were to zoom in on one of the walls of the blood vessel is coated in endothelial cells. These are the cells that make up the blood vessel wall lining. They have nuclei, just like all cells. Well, we shouldn't say all cells, but most cells. But what can happen is these cytokines, when they attract the inflammatory response, as well as some of the receptors on the endothelial cells, causes some capillary leakage. So these endothelial cells start to create openings within the blood vessel wall that allows fluid and cells and molecules to leak out of the blood vessels into the interstitium. And that's increased capillary permeability or capillary leakage. So you get vasodilation, capillary leakage, hypotension. All that can lead to organ hypoperfusion. Your blood vessels aren't able to get enough blood to the organs to oxygenate them. And that leads to that more kind of pathophysiologic definition of shock, that is tissue hypoxia, or not enough oxygen to the tissues. That organ injury and that tissue hypoxia can lead to that classic lactic acidosis that we talk about, an elevated lactate that so often can come with septic shock, although not always, but most times. And this is a spiral, because as you get more damage to the blood vessels, you get more release of inflammatory mediators, you get more of that vasodilation, capillary leak, and this is an incredibly complex process. There's microthrombi and kind of relative adrenal insufficiency and all sorts of stuff, which we're going to dive into in the more advanced videos on septic shock pathophysiology. But yeah, this general pathophysiology is this spiral that ultimately, at the end of the day, leads to multi-organ failure, multi-organ injury. Right, you can get sepsis-induced cardiomyopathy, which is injury to the heart. You can certainly get acute kidney injuries or AKIs. You can get acute liver injuries or ALI. You can get acute lung injury, another ALI. All of these things can result from septic shock once you start to get that tissue hypoxia. Okay? All right, what is the clinical presentation? Well, the classical clinical presentation is related to what is going on. All right, so the signs and symptoms, you have to have infection first. And signs of infection can be things like fever, also low temperature, hypothermia, things like altered mental status. You can certainly have any signs of infection, burning when you pee, blood in the urine, skin rashes, productive coughs, abdominal pain, vomiting, diarrhea, all of those things that suggest infection. And then you get some signs and symptoms from the end organ injury, the hypotension, or all those pathophysiologic manifestations. And those signs and symptoms include legitimate hypotension. But before you get hypotension, you often get tachycardia, because as your blood pressure drops, what do we know? We know that cardiac output equals heart rate times stroke volume. So as your blood pressure drops, to try to maintain cardiac output, your heart rate goes up. So even before you're hypotensive, you're often tachycardic, okay? And then once your body's unable to compensate, eventually you'll be both tachycardic and hypotensive, but tachycardia usually precedes the hypotension. Now, there is a lot of caveats to that. Someone's on a beta blocker, or calcium channel blocker, some other AV nodal blocking agent, or they have other comorbidities that prevent them from mobilizing tachycardia. And then tachypnea. I always say that when someone is tachypnic without lung pathology, it's a really ominous sign, because it could be suggestive of just overall metabolic demand. Oliguria, or decreased urine output, all these kind of go hand in hand. These are all kind of signs of either compensated or decompensating shock. So signs of infection, as well as signs of blossoming hypotension, blossoming compensated, decompensated shock, all that good stuff. And when to expect it, we will talk about this triad of infection, hypotension, and elevated lactate. That's when it's kind of smacking you in the head, right? If you've waited until you have an infection and hypotension and an elevated lactate to say, hey, look, we got it, we got septic shock, you're way behind the 8 ball. So really try to identify it. We sometimes talk about these things: compensated shock, which sounds like an oxymoron, because how can you be in shock if you're compensated? All right, but for the definition of the term shock, we talked again, tissue hypoxia. And you can have a small amount of tissue hypoxia or impending tissue hypoxia while still normotensive. And this is that compensated shock. Because as we said, as your cardiac output is heart rate times stroke volume. And as you get hypotensive, you try to crank up your cardiac output to maintain tissue perfusion. And to maintain that tissue perfusion and to increase your cardiac output, your heart rate goes up. And as your heart rate goes up, you might still be maintaining organ perfusion at this point. And this is when shock is compensated. All right, maybe you just have a wide pulse pressure, low-grade tachycardia. Maybe you're a little tachypnic. Maybe you're a little confused, a little altered mental status. But at this point, you're still maintaining organ perfusion. Okay, but at some point, this compensatory mechanism is no longer adequate. And that's when you start to get the blossoming end organ injury. And this is when your shock is becoming decompensated. But the best time you can identify septic shock is when it's still compensated, before it's in florid, in your face, infection, hypotension, and lactate. Because if you resuscitate and treat aggressively, that initial kind of compensated shock, people might call it severe sepsis. This is another term on the spectrum of sepsis, right? You start with sepsis, which is just infection. Then you get severe sepsis, which is infection plus organ injury, but without hypotension. And then you have septic shock, which is what we're talking about today. And the severe sepsis category is kind of this compensated shock category. And intervening aggressively there can make a huge difference, because once you get to septic shock, we already talked about that the mortality is really quite high. All right, so if you get to that septic shock phase, you're a little behind the 8 ball, whereas if you can intervene when it's sepsis or severe sepsis and prevent it from progressing, that is when you can really make a big difference. All right, diagnosis. Again, we have the formal diagnosis that people talk about, which is require vasopressors to maintain MAP of greater than 65 despite fluids and a serum lactate of greater than 2 despite adequate fluid resuscitation. You certainly need a infection as well. So the 3 components for the formal diagnostic criteria are 1, suspect infection, 2, persistent hypotension. The persistent is important because it has to be after fluids, and the 3, elevated lactate. Now, this is per those sepsis 3 criteria. There's still kind of SEP 1 guidelines that we talk about too, and SEP 1 is just a lactate of greater than 4, independent of whether someone got fluid, or hypotension after fluid. So persistent hypotension defined as a MAP of less than 65 after IV fluids. So there's that formal criteria, and then there's kind of the informal, more pathophysiologic definition, which is those signs of tissue hypoxia plus infection. And this is probably the most important bedside definition in our humble opinion, this tissue hypoxia plus infection, because as we said, there's a lot of different relative scales of compensation that different people can do, whether you're young, old, comorbid, not comorbid, all that kind of stuff. So sometimes we feel if you wait until it's florid, by the book, septic shock, it's pretty easy to identify then, and probably behind the 8 ball. So really look for signs of blossoming tissue hypoxia and infection. But for formal criteria, when you're talking about, what's the diagnosis of septic shock, and there's all the kind of criteria guidelines and stuff that you have to abide by to meet compliance standards. This is the formal definitions provided. Step 1, lactate greater than 4, or hypotension after fluid resuscitation. And then the newest SEPS 3, which is suspected infection plus persistent hypotension plus elevated lactate greater than 2. All right, initial management. This initial management is based on, again, this bundle that people talk about. People talk about the 3-hour bundle, the 6-hour bundle. There's a push to have a 1-hour bundle, although this would be incredibly hard to achieve and is not in full force after a lot of the organizations went and said that seems like something that's not going to be very achievable. So we still have 3-hour bundles and 6-hour bundles. All this, though, is these kind of mandated compliance standards. So that's what some of this initial management written here is, which we'll go through. But there's also just some general management concepts that are probably more important to think about. So initial management, the first concept is fluids. As we mentioned, these patients get vasodilation. and these patients get increased capillary permeability. And they probably have been sick and not feeling good and not eating and drinking much. So most of these patients, not all, but most of them are hypovolemic. They're intravascularly depleted. And what the sepsis bundle criteria would suggest would be that they should get 30 cc's per kg of intravenous crystalloid. Now, this is probably going to fall out of favor, and probably has fallen out of favor in some places, but this is the standard for compliance that they use, and some patients certainly benefit from this. But other patients need kind of a more dynamic volume assessment. How to do that dynamic volume assessment is part of incredible wide-scale debate. Some people talk about ultrasound, some people talk about fancier ultrasounds like VTIs and Vexus and all that kind of stuff. Some people talk about trending lactate. Some people talk about pulse pressure variation and straight leg raise and fluid responsiveness. And is it fluid tolerance, intolerance, and responsiveness? And is it a linear progression or more of a spectrum? All these are really advanced topics. Things we'll probably cover on the channel in the future. But the start of this is that most of these patients do require intravascular fluid. Compliance bundles would suggest you should give 30 cc's per kg, but we're a fan of more precision medicine with some dynamic assessments. All right, blood cultures. All these patients should get blood cultures. It's important to try to identify what organism is causing this infection, and then they should get IV broad spectrum antibiotics. The keys here are IV intravenous and then broad spectrum. And this doesn't have to be the most broad spectrum, but some degree of broad spectrum antibiotics. If they're hypotensive, we should use vasopressors. The first line vasopressor recommended is norepinephrine, brand name Levophed. This is the first line vasopressor for many, many conditions, including septic shock. So if the MAP is less than 65, low threshold to start norepinephrine. And then you want to monitor things. We still trend lactates. There's certainly some debate there. Monitoring the MAP, monitoring urine output. So really monitoring signs of end organ dysfunction, okay, is the big thing here. So make sure the kidneys are working with good urine output, trend the creatinine, trend the liver function test to make sure they're not developing acute liver injury, trend the oxygenation, make sure they're not developing acute lung injury, watch the cardiac function, whether that's with bedside ultrasound or other modalities, trend the lactic acid. Don't put all your eggs in any one of those baskets and be reactionary, but all of them together can kind of paint a little picture about general organ perfusion. Additional consideration, source control can be very important. So you always want to make sure that there's source control. If someone has an abscess, it needs to be drained. If someone has an obstructing stone, obstructive nephrolithiasis with hydronephrosis, they need to have drainage of that, whether it's a ureteral stent or percutaneous nephrostomy tube. If someone has cholangitis, they need decompression of their biliary tree. If someone has necrotizing fasciitis, they need debridement of that infected fascial plane. Sorry about that. So source control is important. When patients are not getting better, sometimes it's because they have a source that has not been identified. So that's something to think about that you might have to come back to. Steroids, if shock is refractory. There is some debate, although I think most people would agree that stress dose steroids are indicated, although when to start those steroids, which steroids to choose, is it hydrocortisone or hydrocortisone plus fludrocortisone or something different? Lots of debate there, but if someone has persistent vasopressor dependent septic shock, most people would agree that steroids are probably indicated, but again, some debate in the literature. And then monitor glucose is you want good glycemic control, and then in addition to that, early nutrition can be important too, assuming perfusion markers are improving, that their vasopressor requirements are going down, maybe their lactate's going down, and consider early enteral nutrition. Prognosis and outcomes, unfortunately, and mortality, as we said, is somewhere between 20 and 50%. Early recognition and management does reduce the risk of mortality. How much is unclear, but we've hit a little bit of a plateau. We probably need some more aggressive research into other ways we can help treat these patients. But identifying early and treating aggressively early is absolutely critical in trying to blunt some of that downstream morbidity and mortality. We do have a little visual summary here. If you're listening to the podcast, we'll read some of it. If you're watching the video, we do have a little summary slide here. And that is septic shock definition. To review, sepsis with vasopressors needed to maintain a MAP of greater than 65 and a lactate of greater than 2 despite adequate fluid resuscitation with signs or suspicion of infection. So pathophysiology, infection leads to immune dysregulation, which leads to vasodilation, capillary permeability, hypotension, poor tissue perfusion, lactic acidosis, and end organ injury. Clinical presentation, we often see whatever is causing the infection, as well as altered mental status, tachypnea, tachycardia, fever, hypothermia, hypotension, elevated lactate. You certainly don't often have all of these things. You might have just a few of them, and that is much more typical. And management concepts are intravenous fluids, whether that's 30 cc's per kg, as some of the guidelines would suggest, or whether that's a more dynamic volume approach, some to be debated. Broad spectrum antibiotics early, get blood cultures, and support patients with vasopressors for MAPs of less than 65. Norepinephrine, we spelled it wrong. Clinical pearls, something that comes up sometimes I hear people say, which is kind of catchy and true, but time equals tissue. Like people say time equals brain with stroke and time equals myocardium. It's not necessarily different for sepsis, right? Now, some of those organs bounce back better than something like a brain or a heart does. Your kidneys and liver might bounce back a little better, but time does equal tissues. The longer those tissues and organs have hypoperfusion from septic shock, the more damage they're going to have, and the more kind of chronic damage they may have. So treat early, treat aggressively, and have a low clinical index of suspicion so that you diagnose this early enough. Clinical pearls here, lactated ringers is often preferred over normal saline. This is highly debated. We personally often use lactated ringers, although there is evidence to suggest that it might not matter. There's evidence to suggest that lactated ringers are better, so highly debated. And then reassess frequently. This is really important. These patients are not resuscitate them once and forget about them. These are patients that need frequent reassessments to make sure you're doing everything you can to get source control, treat the underlying infection, and support the organs with vasopressors, fluids, and what have you. So not set and forget it. Definitely dynamic reassessments. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.